老师你好。哦，我的心。
Okay. Hello, everyone. Online, especially clinicians in the front line to fight with the COVID-19 disease. It's my pleasure to be a moderator tonight. I'm Dr. Wang Xiaoting, come from Beijing. I'm an ICU doctor. I worked Peking Union Medical College Hospital. I'm the president of critical care, Chinese critical care ultrasound study group. As we all know, in the past 2 months, COVID-19 disease developing persistently. Now, from epidemic to pandemic, it's not arrive the disease climax, so become severe and severe. Death is increasing. Critical illness become more and more increased, become more and more. So urgent knowledge for clinicians caring for the sickest of the patients is needed. In the past months, we set up a serious course about the diagnosis and the treatment of the critical COVID-19 patient, especially in ICU. So based on the critical ultrasonography, in the special circumstances, especially ICU for COVID-19 patients, the application of critical ultrasound is very important. So, to my joy, today we have 3 moderators. One is me. The second guy is Professor Yin Wanhong. Let him introduce himself. Thank you.
Okay. Hello, everyone. I'm Dr. Wan Hongyin from West China Hospital, Sichuan University. Also, I'm a member of, I'm a vice chair of Chinese Critical Care Ultrasound Study Group, and I have been fighting in Wuhan against COVID-19 for nearly 2 months. It's my honor here to join the meeting to discuss how we fight with COVID-19 with you. Xiaoting.
Okay, it's Beauty Professor Zhu Ran's turn. Introduce yourself. Thank you.
Thank you, Xiaoting. It's my honor to attend tonight's webinar and also as a co-moderator. I'm Dr. Zhu Ran. You can call me Dr. Zhu. I'm an ICU attending coming from the first affiliated hospital of China Medical University. I'm also the vice chair of CCUSG, which is the Chinese Critical Ultrasound Study Group. That's all. Thank you, Xiaoting.
Yeah, it's my honor too today to invite the important person. Today's topic lecture is about application of critical ultrasound in biosafety level 3 ward. The Professor Ding Xin will hold a lecture for us. Let's begin.
Hello, everyone. I'm Dr. Ding from the Department of Critical Care Medicine, Peking Union Medical College Hospital. 2 months ago, I came here in Wuhan with some of my colleagues and worked in the ICU dedicated for the patients confirmed with COVID-19. And today, I'm very glad to have this chance to share with my experience with doctors all over the world, and I think it will be helpful for you. Today, my topic is the application of critical ultrasound in the Biosafety level 3 ICU. The time I started to work in Wuhan, the COVID-19 disease was only a big challenge in China. But we can see that now things are getting worse all around the world, and thousands of the patients has lost their lives. In China, the percentage of the severe cases is about 15, and many of the patients needed respiratory support. And that is obviously much higher than the other kinds of flus, such as H1N1, and that is why we ICU doctors are very important in this campaign. And as I know, about 10% of the ICU doctors in China has been recruited in Wuhan to fight against this disease. At first, I have to emphasize that most information in this lecture is based on my personal experience, although I have looked up many papers and recommendations in and outside China. So I think it was necessary to introduce the basic conditions of the ICU I'm now working. We are in a designated hospital for only for COVID-19 patients, and most of the staff are from the different places of China. The ICU I'm working was a newly formed 32 beds and is managed by doctors and nurses from Peking Union Medical College Hospital, that's my mother hospital, and about only 20% of them are from the ICU. And the case we are facing are almost severe type and critical type patients. In the documentation in China, if the patients meet any of the following criteria, that means respiratory distress and respiratory rate larger than 30 beats per minute, oxygen saturation less than 93% in the resting state, and if the oxygen index less than 300 milligram mercury, or if the lung image shows multilobular lesions or lesion progression larger than 50% within 48 hours, are recommended to be treated as severe patients. And for the critical type, if the patient develops respiratory failure that require mechanical ventilation, and if the patient has shock or combined organ failure required ICU monitoring or treatment, and that will be called the critical patient. And most of our patients are critical patients in our ICU. Till now, although there are some antiviral drugs or immunotherapy methods were recommended in the diagnosis and treatment protocol for novel coronavirus pneumonia released by the National Health Commission of China, such as chloroquine, remdesivir, and interleukin-6 blocker. But no drugs have been proven to be very effective in the COVID-19 patients with power evidence, and especially in the critical ill patients. Actually, in most of our patients, the nucleic acid test often has become negative, and the antibodies have turned positive. So for these patients, we are dealing with the consequence caused by the virus, but not the disease itself. So the basic treatment of the ICU should still be focused on. That means we have to do lung protective ventilation strategy. We have to do enough hemodynamic support, microcirculation protection, prevention of hospitalized acquired infection, and the evaluation and management of the ICU. Actually, we think it is what we did in the normal condition in our daily lives. And in our ICU, we have ECMO, ventilators, high flow nasal catheter, CRRT, ECG, bedside chest X-ray, and ABG. But the advanced hemodynamic monitoring methods such as PAC, PICO are not available. And if you want to have a CT scan, that will be very difficult. And in this kind of condition, the work efficiency is about 1/3 of the normal condition. So we think the critical ultrasound has become the most powerful weapon we have to make a diagnosis and to guide the treatment. And we also have some principles for the critical ultrasound exam in this special ICU. And that is, first, personal protective equipment for the medical staff. And you have to prepare the machines. And we have to do the disinfection before or and after the performance. And at last, we have to export the data and the transmission outside the ICU safely. First, the doctors and nurses should be fully protected, and we always believe that the medical staff are the most valuable assets in this campaign, and our government has made its best effort to provide enough personal protective equipment for us, which consists of disposable gloves, surgical caps, shoe covers, medical protective clothing, N95 masks, and goggles or face shield. If you have to do the most dangerous procedures, such as intubation or tracheal bronchoscopy, a positive pressure respiratory protective hold could be recommended for these conditions. Also, and these are pictures and videos of how we do our personal protective. Actually, we have been asked so many times from the doctors outside China that if this kind of equipment is overprotected, because in most of the places outside China, the N95 is very, very short, and it is in a shortage of N95 masks, and the PPE is very, very little. But we believe that this kind of protection worked in Wuhan, and none of the 42,000 medical staff who came to Wuhan was infected with this kind of protection. And you can see that the first video was from the internet, and that's exactly how we have our equipment before we enter the special ICU. And the two pictures are the exact pictures taken in our ICU. And next, apart from the personal protection, we suggested that the ultrasound machine should be used only in the ICU where all of the patients were confirmed with COVID-19. So we don't have to worry about that, if the virus could transmit from one patient to another. And we need all the three kind of probes, including phased array probe, convex probe, and the linear array probe. And if you have the ultrasound probe thermal protective strips, it will be very useful. And don't hesitate to use them, not only for the puncture, but also for the original common states. All the parts of the machine should be fully disinfected before or after usage to prevent the nosocomial infection. The mainframe of the machine consists of the casting, display, and the keyboard should be disinfected with the 75% medical ether after every examination. Don't forget to shut down the power during the disinfection procedure, and low-frequency ultraviolet rays should be used, such as once a week. And for probes, as they will touch the body of the patients, they should be disinfected before and after every examination. Disinfectant containing quaternary amino salt or hydrogen peroxide was recommended rather than the medical ethanol, and make sure both the probe and the lines was disinfected thoroughly. After the exam, we will export the images and the videos for further analysis and discussion. As you can't directly take the machine out of the world, we do that in two ways. You can export the images and the videos to the USB flash stack and import them into the computer, then transmit out via the internet. Also, you can upload all the information to the special cloud via 4G or 5G, then read and analyze the data with your smartphone or computer. And some of the ultrasound already have this kind of function. And actually, application, that is how to do the infection control during the procedures. And actually, the application with the critical ultrasound in this special ICU is more difficult than usual because the limited visions and heavy PPE, and I have some steps to share during the performance. First, different postures, different protocols. And as most of our patients are ARDS patients, prone position ventilation is the standard method in the treatment strategy. But when the patient is in the prone position, the common heart and the lung ultrasound cannot be performed. So we suggest that follow different protocols according to your patient's postures. When the patient was in the superposition, protocols such as RAS, blue, or CCUE could be performed. And if the patient is in the prone position, a blue protocol could be performed to evaluate the lung, as you can also evaluate the back and the effect of the prone position. Secondly, we usually do the critical ultrasound in the right side of the bed with the right hand in the normal. But in this special occasion, we suggest that you should act according to the circumstance. In our daily practice, we did that with the right hand, the left hand, and in some special conditions with the backhand posture. Take your ultrasound to a proper place and try your best to get the images, and that is just what we are doing now. Apart from that, the proper holding gesture could also be adjusted. In the practice guideline released by our CTC, we recommend that the pen holding gesture and the grab gesture in performing the echocardiography. But as the narcosis sensitivity is largely decreased with the layers of gloves, any holding method is okay if you can get the standard image. Remember that standard views are the most important rather than the standard gestures. And there is an old Chinese saying says that no matter if it is a white cat or a black cat, a cat can catch rats is the good cat. Furthermore, with layers of grooves, not only your knuckles but the sensitivity of your fingertips are also decreased. So that will make your human-machine interface more difficult. There are usually two kinds of human-machine interface: keyboard and keyboard plus scroll and the full touch screen. No matter what kind of interface you find, the measurements would be influenced. So we just that focus on the qualitative analysis, which means that get information mostly from the videos, but not exactly the quantitative measures. In most circumstances, that will be enough. Quantitative measures could be added if possible. And for the patients with full touch screen, use your digital joints instead of your finger palm will be a better choice. And this is some performance tips I want to share with you. And next, I will jump to the exam phase. And for exam phase, at this time, the recommendations for treatment of critical COVID-19 based on the critical care ultrasound, which is released by CCUSG, are also recommended here. In this recommendation, a standard CCUE protocol, which has been widely used in China, is modified to the MCCUE protocol. And if you are not very familiar, you can ask us about for this recommendation. Patients with respiratory and circulatory fluctuation can first implement the modified CCUE fast-track protocol on the basis of problem orientation, which includes 5 views of echocardiography and the 10 search points of the lung point. The detailed content of the protocol will be introduced in our series lecture. And for critical patients with multiple B-line distribution, the 8 or 12 zoo approaching could be also used in test. And if the quick track protocol cannot meet the needs, quantitative measures such as diameter of the IVC, left ventricular ejection fraction, and VTI could be added. Besides, basic organ evaluation such as the brain, kidney, and gastrointestinal system could also be added. Just as I mentioned, approved protocol could also be applied for evaluating the efforts of the prone position. So for different conditions, different protocols should be chosen. For emergency management, such as hypotension, hypoxemia, and CPR, CCUE or field protocol could be used. For conventional screen or diagnosis and differential diagnosis, MCCUE could help. And for further refined adjustment, advanced CCUE or flow-related echo examination protocols could be used, and you can find all the protocols in our recommendation. When you are doing the cardiac assessment, the following experience may be helpful. As most of the AIDS patients are ventilated with high PEEP, and the left lying position cannot be placed all the time, so don't expect to be able to get all the 5 views of the heart, especially the pensternal views. If you want more information, the short axis information about the short axis of the left ventricle, the subcostal view is the main view that can give you enough information. Look at this patient and look at this ventilation screen. You can see that the PEEP was set at 14 and the prayer spot is 22. And in that circumstance, it will be very lucky to get all these 5 cardiac views. And in most circumstances, the subcostal view would be the only standard view you can get. And you can see all the other views, especially the pensternal view. So in that circumstance, we make a little modification of the subcostal view. After you get the subcostal 4 champs view, you can rotate your probe for 90 degrees, and you can get the short axis of the subcostal view. And also, you can get the short axis of the IVC view. And if you combine the 4 views together, they will provide more information about the patient's hemostat. And it is just enough for you to analysis. And if you are doing the lung ultrasound, pay attention to the differentiation of the B lines because they could be found everywhere. Pneumothorax isn't rare because of the high PEEP and the high peak pressure, and sometimes turn your probe parallel to the intestinal costal space will get a better view, and the efforts of the prone position should be evaluated. This is the typical pictures of the patients in our ICU ward, and you can see that almost you can see B lines everywhere. And as you know, B lines can appear in cardiogenic pulmonary edema, ARDS, and pulmonary fibrosis. As the typical classification of the COVID-19 patients is acute intestinal lesions. B pattern of other origins should be differentiated. And let's see all the image here for the cardiogenic pulmonary edema. And the B lines are multiple, diffused, and bilateral distributed. And pleural lines are rarely affected. And if the echo is abnormal, that will be most likely to be pulmonary edema. And in the typical ARDS, the lesions are usually in the dependent area. Different kinds of patterns can be found, such as A lines, subpleural consolidation, and the lung consolidation. So it is different from the patients with COVID-19. And in pulmonary fibrosis, you can also find the diffused B lines, which are more frequently in posterior of the lung basis. Pleural lines are often thickening with subpleural consolidation sometimes, and the extent of the lung sliding is often limited as the low tidal volume. So you can differentiate them from the change in the pleural line, extent of the lung sliding, morphology of the B lines, and distribution of the B lines. And this is the summary of how to distinguish different etiologies of the interstitial syndrome by the lung ultrasound, mainly in the following several aspects: clinical settings, B line numbers, B lines distribution, other lung ultrasound signs, and echocardiograms. Apart from the B lines, recognition of the pneumothorax is also important. There are several risk factors in the ventilated COVID-19 patients. For example, a very high platform prayer, more frequent recruitment renewal, and decreased lung compounds. Actually, in these critical patients with ventilators, A line are very hardly to see. And if you found a typical A line, you should be very careful to identify the pleural sliding to make sure if it is the pneumothorax. Remember, lung sliding, lung pulse, consolidation, and the B lines can only rule out pneumothorax, and only only when the lung point was found, the diagnosis can be confirmed with this ultrasound. Although most of the time we prefer to make the probe perpendicular to the ribs, as it is easier to get the best sign, and it is enough in our daily lives. But in this special condition, make the probe parallel is a good choice, such as identifying the lung point and identifying the B lines. You can see the perpendicular way is good at identifying the back lines and pleural lines, and the advantage of the parallel way is that the pleural line is full extended, and the regions in or under the pleural lines can be more obvious. So the two ways can be combined to diagnose the patients. At last, but not least, I want to comment something about the prone position ventilation. As we know that prone positioning is one of the several effective methods to improve the mortality of air deaths. But in the critical practice, we always have to face some difficulties, such as shortage of human sources, tube safety, and so on. And sometimes after the prone positioning, carbon dioxide retention could be more serious. So I think with the advantages and disadvantages of prone positioning is necessary. In 2016, we published a paper in the Critical Care about the potential of prone positioning and assess the prognosis in patients with acute respiratory distress syndromes. In short, you can do the lung ultrasound exam immediately after the procedure, or 3 hours after that, and you can compare the results of the two exams. If the lung improved significantly, the PPV is of much importance for the patient, and you have to stick to that for more than 16 to 20 hours anyway. Such as the picture show, you can find them in concentration have turned to A lines. That is the best efforts. But if the B lines predominantly and doesn't get any better at all, most likely the patient couldn't benefit from the prone positioning, and the more advanced technique such as ECMO may be needed for this patient, and you cannot have that great benefit from this method. And if your patient have been in the prone position for a long time, such as 1 week or longer, you should pay attention to the upper part of the lung and to see if the consolidation has already developed in the front. That is not so common, but it really happens. And then you can see this picture. Before the prone positioning, the upper blue point is B lines, EB pattern, but after 1 week of positioning, you can see obvious consolidation of these patients in the front. So in conclusion, critical ultrasound is a very useful weapon we have in the campaign against the COVID-19. Application of the critical care ultrasound should still be stick to the technique specification, but image acquisition to guide the clinical practice is the first requirement in the Biosafety level 3 ICU, and you have to pay much attention to the infection control as they are very important. Protocols should be chosen according to the situation, and the application of the echocardiography and the lung ultrasound should fulfill the characteristics of the COVID-19, and we'll share that with you in our series lectures. At last, I want to show you the pictures of our CCLT members who are working with me in the front line in Wuhan, and pay my highest respect to the medical staffs who are fighting in China and all over the world. And I hope our limited experience in Wuhan will be helpful for you. Thank you for listening. That's all.
Liu Gong. Hi, I'm sorry to everyone. Dr. Ding Xin have an important phone, maybe about the critical ICU patients. So it's time to chatterbox Q question and answer time. The chatterbox moderator is Professor Zhu Ran. Hi.
Hi.
You can begin.
Okay. Thank you, Xiaoting. Here comes our Q&A session, and I will host this session for all of our audience. I think we already have a lot of questions from our audience, and I will choose some meaningful ones and read about the questions and ask one of my colleagues to answer it. So let's begin. Here I got a question of what's the disinfection procedure of the probe during COVID-19 patients? I have seen a lot of questions about that, and I think this is a topic Professor Ding Xin just gave us. So I will try to answer some of them instead of Professor Ding Xin because he has some meeting and leave for the meeting. So I think for the disinfection procedure of the probe and for the ultrasound machine, we have some rules for that. The first rule is we must have a specialized ultrasound machine in the isolation unit. So we can use that specialized machine for all confirmed COVID-19 patients. So that's the first rule. And then we need to think about the disinfection procedure depends on what the procedure is. So we must disinfect the probe and the line before and after the examination. That's the second rule. And for the main part of the machine and for the probe and line, that's different. That there will be different strategy for the disinfection. And for the main part of the machine, we will use 75% medical alcohol to disinfect the machine, and maybe use some UV light to have the machine disinfected once a week. So that's the rule to disinfect the ultrasound machine. And for the probe and the line, we must disinfect the probe and line thoroughly before and after the examination. Just we use the ultrasound machine to examine our regular patients, not COVID-19 patients. And usually for that disinfection, we use some wet towels containing ammonium salt or hydrogen peroxide. So that will not be harmful for our probe. I mean, to decrease the efficiency of the probe for a long time. So that's we use for our probe and line. And if we want to use the ultrasound machine to guide some sterile procedure, like we use ultrasound guided CVC injection or ultrasound guided PICC injection. So we need some protective sleeves for our probe and line. So that will make the procedure more safe and prevent the hospital-acquired bloodstream infections to our patients. And I think should be mentioned about the PPE. The PPE for an ultrasound examiner, that means for some ICU practitioner who practice the ultrasound in the isolation room, they must protect themselves as he gets some specimen or doing some Euro examination. They just wear the Euro PPE like a wardrobe, the CAT, the N95 mask, and face shield or goggles. You can choose one of them, and you need to put on some disposable gloves for 2 or 3 layers as the adequacy of equipment you have in your hospital. I think that's what I can think for the procedure, the disinfection procedure for the ultrasound machine and for the ultrasound probe. That's all. So any comments from our Professor Wang and Professor Yin?
I totally agree with you. I just want to take another emphasis about what you mentioned about before and after. It's the key part. Before and after. Every time, maybe every time, every doctors, if you want to take a ultrasound examination for the ICU patients, maybe the probable of this infection is needed before and after. And then the second point I want to take another emphasis is that it's very important. Dependent on the procedure. Just like different procedure and maybe the same level of protect yourself. Just like if you get into the ICU world, especially for the critical COVID-19 patients, the BSP level 3 is needed. And when you face a very important isora generating procedure, maybe the level increase, just like a face shield and positive pressure, postoperative area, and maybe something else. Level increase. Thank you.
Thank you. And we have some other questions not related to our today's topic. Here I get a question of how accurate is lung ultrasound as compared with X-ray and CT. So I will ask Professor Yin Wanhong to answer it, please.
Okay. Well, we had talked about this question so much. Firstly, we will say that they each have advantages themselves. If we can use them in a collaborative way, they can help each other well. And we could, if we combine the information from the 3 methods, we can get enough information to make a clear design to promote the treatment. Secondly, if you want to be clear what the advantage is, we see that if you want to get a clear picture about the lung, you can choose a chest CT firstly. It's back for the risk of the transferring of the patient, and the non-ultrasound is good at detecting the pathophysiological changes of the lung, especially the mismatch of the air and the water, and to detect the mismatch of the ventilation and the perfusion, also as well as the fluid diffusion and the consolidation and others. So it depends your purpose of your treatment, of your monitoring. If you want to know well about the non-picture, know well about the non-image, the chest CT or the non-ultrasound is the first two choice. And if you want to know well about, know clear about the primary pathophysiology of the patient, you choose non-ultrasound to know the distribution of the air and the water, and to know the mismatch of the ventilation and the perfusion. Okay, that's all.
Thank you. How about Xiaoting?
That's all. Thank you.
Okay. So we'll move on. Here we got another question about disinfection and protection. The question is, if laboratory personnel collect blood or respiratory specimen or US scanning directly from suspected or confirmed COVID-19 patient, what PPE do they wear? I think this is a question just on the contrary of the disinfection of the probe, just like the first question we answered. This is to how to protect our medical staff. So we have the Euro rule for all the medical staff all over the world, not also in China, just all over the world in US or in Europe. So it depends on, no matter what specimen you will collect, the sputum, the blood, or you will do some US practice or scanning. It just depends what kind of route the coronavirus will transmit to our medical staff. So if you are considering about contact transmission, or you are considering about aerosol producing procedure. So it depends what kind of procedure you are doing. So basically, we will have some N95 mask as a basic to protect the aerosol producing procedure. And if you are going to do some bronchoscopy, sputum collection, or intubation for your critical ill COVID-19 patient, maybe you will choose some goggles or some face shield to prevent the aerosol producing procedure. And of course, you need some disposable gloves for 2 or 3 layers to protect your hands. And sometimes we just wear another surgical mask outside of the N95 mask to protect or to save the use of N95, to reuse N95 mask for us. And of course, we need some medical protective clothing, the cap and the shoe wear, something like that. And I think for the pandemic COVID-19 all over the world, no hospital will have enough equipment or PPE for our patient and our medical staff. So you could be protective, as protective as you could, as possible. But it depends on how many PPE equipments you can get from your hospital, how many PPE your hospital have for your medical staff. So the basic ones are for the aerosol producing procedure, and some are just for some contacting procedure. So you can choose and be prepared. So that's all. So if there's no comments from Professor Wang and Professor Yin, we'll move on.
Just what I mentioned just now. If you need to get into the ICU wards about the critical COVID-19 patients, you have the BSS level 3 protect level. So every time you need to, maybe face a great procedure, just like what I mentioned, aerosol generating procedure. Maybe the level need to increase, just like maybe positive pressure positive risk predictor for the ICU doctors. So that's all. Thank you.
Thank you, Xiaoting. So we move on to the next question. Under biosafety level 3 ward, if it will influence the image quality for the early diagnosis? I think that's a very meaningful and important question. So please, Professor Wang Xiaoting.
Yeah, it's a good question because every time some my colleagues take a question, the same question for me. Every time maybe I will answer this question about like when you face the critical COVID-19 patients, you take a critical ultrasound examination for the patients. Every time you face the same patient, you same the question under biosafety level 3 ward, if it will influence the image quality for the early diagnosis. Every time I want to tell everyone about just you take examination for the patients. If you maybe take a lung ultrasound patient, every time you maybe think it over. Just like what's the findings of lung ultrasound? It's B line, it's B3, B7, maybe the diffuse B line and the consolidation. Okay, every time you get the exact diagnosis, maybe you can got exact evaluation for the patient from the lung ultrasound. All the information depends combined the clinical manifestation, clinical information about the patients, especially the patient position, posture, and the mechanical ventilator support level. Just like the PEEP is increased to 50 centimeter water, maybe 20, maybe higher. So every time you want to got an exact, correct evaluation of the patient from the longer ultrasound, you need to combination with the detailed clinical information of the severe ICU patients, especially COVID-19 patients. The two key points. One is the posture, maybe the PPV, the prone position. Maybe another point is mechanical ventilation support level. So it's the first aspect. In the other aspect, maybe you did echocardiography, maybe an echo examination for the patients. When the patients have an intube and have a higher mechanical ventilation support level, especially higher PEEP, higher tidal volume, maybe higher level, higher support level. In the most secure situation, you cannot acquire a standard view about the heart from the thoracic. Maybe you need to take a new position. You can acquire the exact findings of the echocardiogram, just like a subcostal view. Through this view, through the subcostal view, you can find the 4-chamber view, and every slice, the short X view of the heart, and the long pulmonary artery view about the patient, about maybe another view, just like an IVC view, short X and long X. So maybe the subcostal is a key is a key position to acquire the views you needed. So it's a second situation. Maybe there's lots of the very, very different and different situation, but you need to do the echocardiography for the patient to find the exact findings, exact evaluation for the patients. Maybe you can take a examination through the TEE. It's the Professor Iman Hong's favorite. Maybe something about the transesophageal echocardiography for the COVID-19 patients. Maybe he have his comments. Maybe. Thank you.
How about Wan Hong? No comment.
No, we do not perform TEE because of the situation in the front line. So maybe we can talk about TEE in a special issue for the other time.
Okay.
Thank you.
So let's move on. We have some other questions, and the next one is, did you use pulmonary echocardiography to all patients with COVID-19? I think it depends. It depends on if you have a machine in your department, and depends on what kind of patient you have. Since we are all from Chinese critical ultrasound study group, we are trained for critical ultrasound, and we are all ICU practitioners. So for me, yes, I will do the ultrasound for cardiac echocardiography and ultrasound, and the ultrasound for other organs for all patients in my ICU. But I will ask the opinions from the other two. So please, Professor Xiaoting.
No. So maybe for me, it's correct too. I think Professor Iman Hong have lots of the experience about this question.
Well, I do pulmonary ultrasound, non-ultrasound for every patient when I rounding the patient, and since be clear and the decision is well made because I know well about my patient. So I recommend you to do pulmonary ultrasound to every patient, but in the reality, we can say we should try as possible as we can.
Okay.
I think Professor Zhu Ran's answer and Professor Iman Hong's experience totally is great. So in my ICU, every patient, if you want to get the detailed information of the patients, especially when the patient faces critical events, every patient needed. Thank you.
Thank you. So we have only several minutes left, so we just have one or two questions left. Another question is, usually one ultrasound equipment is used for how many ICU? It depends. How about in your hospital, Professor Iwan Hong?
Well, yes, I agree with Dr. Zhu. It depends the severity of the patient and the frequency you use in your work. I worked in a ICU in Wuhan with 17 beds, and I have 2 handheld machines which can fulfill my requirement when I do the rounding. And I offer you a good news about the requirement of the machine, that we are working on a survey on the demands of the machines and the training course, what we need to fight against the COVID-19 disease on behalf of Chinese critical ultrasound study group, and will gather the answers from the fighters in the front line about the requirement and the training course they want. We'll offer you the data in another time.
Okay, that's all. So we have another question, but I think none of us could answer that. It is about how about give betadine solution for inhalation. So I never use this kind of meditation in our unit or in our hospital, and none of this kind of inhalation medication is described in our Chinese guideline for each version. So we don't have an exact answer for that. So that's all. I think it's all for today's Q&A session. And I will ask our president, Professor Wang Xiaoqing from Peking, to give a conclusion. Please, Professor Wang.
It's a difficult question because the question indeed for lots of ICU doctors, maybe the clinicians in the front line, every clinician have a question in his heart. There will be a bullet, a magic bullet, can kill lots of others and can save lots of thousands of COVID-19 patients. But we have no. I want to see lots of doctors, lots of clinicians in the front line for fight for COVID-19 patients. Maybe we have no magic bullet, but we have a heart to fight the COVID-19, to fight the virus, and the key point of the patient treatment, it's a protective strategy. The protective strategy, just like the circulatory protective and the lung protective and lots of organ protective strategy. So I have lots of maybe experience in the duration of this epidemic of COVID-19. The key.
I think there has some problems with the web. It's okay. Please go on.
So the key point is the protective strategy for every patient.
Thanks for the comment. And I think it's come to the closure time. So who wants to make a conclusion, a summary? How about you?
I think the key comments
is a
maybe you are suitable because you are the moderator of the chat box for Q&A. Thank you.
Thank you for the opportunity. I think all of us have the basic idea of how to wear a PPE, how to prepare for our taking care of our critical ill COVID-19 patient, and how to prepare our machine. At least we need an ultrasound machine to collect basic and important clinical information for our critical ill COVID-19 patient. So we will keep move on for this webinar series, and I will make a forecast for the next webinar. I think it's on Thursday this week, and chapter 6 is the topic is critical ultrasound protocol and approach in COVID-19 management, and the speaker is Professor Chen Mingming from the same hospital with me. I think it's all for today. It's a wonderful night. Okay.
Thank you. Thank you. See you.
Okay. See you.
See you next time.
See you.